Good morning, and welcome to the 20th Annual Zarrow Mental Health Symposium. For the next 2 days, we're going to be focusing on all things prevention, starting with Dr. David Shern's opening presentation, The Mental Health Revolution in Public Health. My name is Al Carlozzi, and I am co-chair of the Mental Health Association Oklahoma's Education Committee. This group of dedicated volunteers helps plan this conference each year. For those of you who were with us last year, you may remember that Mental Health Association in Tulsa's executive director, Mike Brose, made a big announcement that the organization soon would be changing its name. Well, today I'm proud to serve as a board member and incoming board president of the newly named Mental Health Association Oklahoma. Thank you. I'm so excited that the association is now a statewide agency advocating for Oklahomans impacted by mental illness and homelessness. Now, on behalf of the Mental Health Association Oklahoma and our longtime conference partners, the Oklahoma Department of Mental Health and Substance Abuse Services, I would like to give special thanks to those who have made this conference possible. 20 years ago, Maxine Zarrow and her late husband, Jack, helped us to found this conference. Over the years, their daughter, Gail Richards, and other members of the Zarrow families, along with foundation staff, have played a key role in helping us to develop and grow this conference into one of the premier educational events in our region. We truly could not have done it without their vision and support. Many thanks to our longtime supporters and 2014 presenting patrons, Phyllis and George Dotson and the Zarrow Families Foundation. We are so grateful that they are among a list of more than 60 sponsors and exhibitors that have stepped up this year to lend their support. Please join me in saying thank you to our silver sponsor, Oklahoma Disability Law Center, for generously sponsoring this morning's breakfast. You'll find a complete list of conference sponsors and exhibitors in your on-site program. We encourage you to visit their booths and learn about how they're making a difference in our communities. Our goal for this symposium is to provide insight and access to groundbreaking research and emerging knowledge in mental health. And our vision is that all of the ideas shared over the course of the next 2 days will help transform care and ultimately improve the lives of those impacted by mental illness, along with the lives of the people who love and support them. So again, thank you all for being here with us and for being a part of that shared vision. Participate, learn, have fun, network, and enjoy each and every minute of this experience. One important housekeeping note: please be sure to sign in each morning at the conference registration desk. This is especially important for those of you seeking continuing education credits. We also ask that you sign in at each breakfast session you attend. This is especially important if you are, we also ask that you sign in at each breakout session that you attend. If you want to sign in at breakfast, that's okay too. This is especially important if you're requesting CEUs or CMEs. And now it is my honor to introduce Dr. David Shern, Senior Public Health Advisor for the National Association of State Mental Health Program Directors and the Senior Science Advisor for Mental Health America. Dr. Shern is considered one of the nation's leading mental health experts. He served as interim president and CEO of Mental Health America from 2013 to 2014 and previously led the organization from 2006 to 2012. As an affiliate of Mental Health America, Mental Health Association Oklahoma has enjoyed working with Dr. Shern, and we all appreciate his 30 years of distinguished service in mental health services, research, and system reform. And we thank Dr. Shern for being here today to share his thoughts on the mental health revolution in public health. Now please join me and welcoming Dr. David Shern.
Thank you, Al. Good morning, Tulsa. Terrific to be here, and terrific to be able to talk to you and sort of kick off the general session on what I see as sort of the new emerging issue in terms of behavioral health, mental health, and substance use conditions, and our nation's health overall. Al, said that this is a premier regional training event. Al, I think it's fair to say this is a premier national training event. And the Mental Health Association in Tulsa and now Oklahoma should be very proud of the way they've developed this into the event that it is, consistently delivering very high quality, timely information for the entire region and nation. So it's great to be here. And what I want to talk about today, after I tell you that I have no commercial interests in anything that I'm going to be talking about, so I'll give you the disclaimer, is I'm going to tell you a little bit about the history of public health revolutions, the things that have really fundamentally changed our health. And what we're going to see is that the biggest effect on our overall health in terms of our history was the development of the germ theory and the public hygiene movement. Revolutionized health, expanded longevity, reduced the morbidity and disability associated with infectious illnesses. Nothing has changed our health more than that. And what I'm going to do is I'm going to present an argument that says that the current epidemics we're experiencing in our country, and it's an odd time to give this talk because this is in the context of watching this infectious disease in Africa, Ebola, in the context of a underdeveloped, under-resourced healthcare system slowly starting to go out of control, that we need to appreciate the importance of our sort of public health system and the response that we would have to an infectious epidemic, which isn't the case in those Western African countries. Our contemporary epidemics are epidemics that affect our human capital, our productivity, our well-being, and our health. And I'm going to present a lot of data to you today that should be very concerning because we should have some red flashing lights going off with regard to what's happening to our health in this country. They should be principal concerns to us, our competitiveness as a nation and our ability to continue to lead the world in terms of overall well-being. I'm going to argue that we know actually a lot about what causes these public health problems. And those are largely related to behavioral health, to the areas in which we work. I'm going to show you that the costs of these programs are extremely high and that we know what we can do to make a difference. There are common denominators, and those relate to both our genetic makeup and then also the environments in which we live. We're going to talk a lot about toxic stress and trauma as kind of the current infectious elements, if you will, sort of follow this metaphor of using what we understand about the germ theory and carry that metaphor to think about behavioral health. And what are the things that are the infectious agents? What are the things that are epidemics right now? Fortunately, we, over the last 20 years, have developed a very formidable science base that allows us to intervene in terms of what we know about reducing the degree of toxic stress that people experience for people who become ill as a result of trauma. We have a whole series of evidence-based treatment programs, and I know that the Zarrow Symposium a couple years ago focused on trauma, so this is kind of a nice follow-along to that. We know a lot about what we can do, but as in many other areas of medicine, if you take what we know and what we in fact do, there's a huge gulf between the two. And so my call to action to you today is going to be for all of us to work together to start to close this gap, to start to address what are our contemporary epidemics, which reflect our overall well-being, so that we can start to realize what will be the next major era in public health, as big and as important as the germ theory, and behavioral health is going to be the linchpin of that, and all of us who work in this area are going to be the public health champions that bring this next era to fruition. So, Let me talk a little bit about sort of where we've come from in terms of our field, and then do a little bit of historical overview relative to the public health revolutions of the past and then the public health revolutions of the future. In mental health and in other areas of medicine, there traditionally has been a tension between prevention, early intervention, and treatment. And treatment has typically won those battles. So preventive interventions have not been as well funded, as well researched, as well supported, or as well implemented as have treatment interventions. We have a dichotomy, just like we have a dichotomy between mind and body. We have a dichotomy in our own field between prevention and treatment. And what we're going to argue today is that that can no longer be the case. It would be like saying, what would you rather have, vaccinations or antibiotics? You know, if you said that in terms of the germ theory, the infectious diseases, people would think that's a silly question. What do you want, vaccinations or antibiotics? You need them both. In our field, we've got formidable prevention. I'm going to show you we have some things that are like vaccines. They have long-term beneficial effects, and we need to start to pull together our traditions that have traditionally fought with one another to realize this vision. I know next year's Zarrow Symposium is going to be on integration, and there's been a lot of talk about integration nationally as we come to realize that the behavioral health conditions are the most common chronic illness and cause more disability in the United States than any other illness. If you look at mental health conditions and addiction conditions, they cause about 33% of all the disability that we experience in this nation. Cancer causes about 16%, heart disease about 15, 16%. The conditions that are our primary concern in primary care, in general health care, are great multipliers of morbidity and disability and great cost multipliers. And it is essential, and this is happening all over the country all the time, and it's greatly aided by by provisions of the Affordable Care Act that require mental health and substance use services to be mandatory parts of the essential benefit package. But perhaps more importantly, people are realizing that it's impossible for us to effectively manage other chronic illnesses like diabetes, heart disease, arthritis, cancer, unless we manage the behavioral health conditions that are associated with that. And in fact, I'm going to present some data later that says that, you know, we usually think about when you get cancer, you get depressed. You get heart disease, you get depressed. It makes sense that people who have these chronic conditions also have depression. As it turns out, I think, and now I'm speaking beyond the science, this is my conjecture, I think that ultimately we're going to find out that the first conditions that people develop are depression and anxiety disorder. And subsequent to that, physiological changes begin, which ultimately result in diabetes, cardiovascular disease. I think, and again, this is beyond where the science is today, I think we're going to have a new unifying theory that'll show that the things that happen to us, the social determinants of health, have dramatic effects, and the first place that they show up are in behavioral health arenas. The first place they show up is in learning and memory and depression, and we'll get into that a little bit more in the future. You know, traditionally, our medical care system in this country has been a disease-oriented system. We pay on units of service for the treatment of medically necessary conditions. We have incentive systems which actually cause providers to be in a position where they make the most money by providing the most services, not by keeping people healthy. And arguably, it's this system that we've developed, our insurance and our reimbursement system, which is an important underlying factor. And if we have time, near the end of the talk, we'll talk about some of the features of the Affordable Care Act which relate to these kinds of disincentives for health, things like accountable care organizations, medical homes, which really start to look at the health of people who are served rather than simply the elimination of disease. So what I'm trying to do here is to show you that I think we're at a tipping point. I hope we're at a tipping point. There are a lot of cross currents. You can just see the number of states who chose not to expand Medicaid, and I know Oklahoma is one of those states. You can tell there's a lot of tension and a lot of cross currents here, but I really believe that the science is leading us to a position where we now realize the critical nature of behavioral health, the critical nature of growing healthy, vibrant children. And this is kind of our call to action. I think that it's our chance to be the leaders in this. Just parenthetically, I was going to say parenthetically, but parenthetically wasn't on this slide for some reason. But the point I was going to make, which I think is going to come up here in a second, is that Clifford Beers, who was the founder of our movement 105 years ago, along with some very famous psychologists and psychiatrists, William James, who's the father of American psychology, and Adolf Meyer, who is the father of scientific psychiatry in this country and the first chair of psychiatry at Johns Hopkins University, called our movement originally the mental hygiene movement. And to us today, at least to me, that sounds kind of odd. It's sort of like clean brains, right? I mean, but what they were trying to do in terms of mental hygiene is they were trying to emulate what was happening in public hygiene, which changed everything. The difference between then and now, as we'll see in a second, is that they had the vision, but they didn't have the science. We now have the science, and it's time for us to call to action. So, yesterday's epidemics were infectious diseases. We've talked about that. In the mid-1800s, roughly 100,000 people died of cholera in the United Kingdom. With industrialization and children working in industrial settings, their average life expectancy was 15 years for those kinds of workers. Death rates in cities, and this is part of urbanization and industrialization, were twice as high as they were in rural areas. And sanitation was suspected to be a cause for many of these kind of infectious illnesses. Although the dominant theory at the time was what were called miasmas, and that's bad air. So the suspicion was it had something to do with some sort of infectious agent in the air that was causing these problems. For everybody who's taken a public health course, you'll know about the story of John Snow. John Snow was a physician, epidemiologist in London, and John Snow thought that there was something about the water that was actually causing cholera. And so what he did was what we would today call a very careful observational study, an experimental study, and he did a careful mapping of everyone who had come down with cholera in a particular epidemic in 1854. And what he found was a common element among all those people was the fact that they were drawing their water from the same water pump on Broad Street in London. And based on his data, John Snow approached the Lord Mayor of London and requested that pump handle be removed from that pump so people could no longer get water out of it. And when they did that, the cholera epidemic ended. So John Snow didn't understand what was specifically causing the cholera, but he had very strong observational data that had something to do with everybody drinking from the same well. Now, based on his intervention, that epidemic went away, and we now had some of our first information about how this particular very infectious and frightening disease was passed on from bad water to people who were drinking it. But his theory was not proven for another 30 years. Eventually, Louis Pasteur identified the cholera bacillus, and so now we take the next step in terms of our sophistication, right? Snow knew something was going on with the water. He didn't know what it was. Pasteur, 30 years later, started to fill in the science, identified the bacillus that was causing cholera, and then along with Cook and others, really started to develop the entire germ theory of infectious disease, and that changed everything, right? This gets back to the argument we were talking about initially as we started, in terms of overall public health in developed nations. Again, tipping our hat to the horrible and very difficult situation in Western Africa, where they don't have the kind of public health infrastructure that we take for granted in our country. So public hygiene was adopted to reduce exposure to these illnesses. Vaccinations and antibiotics ultimately were developed. Once we had the theory, once we understood that it was these bacillus that were causing these problems, it opened up a whole new world, both for prevention in terms of things like sanitation, public health standards, and then ultimately treatment with antibiotics and antiseptics. The interesting stories about trying to get physicians to wash their hands which continues even till today. And here we make the point about the mental hygiene movement that beer started. The point I want to make here is it changed everything. The observation about what was causing these problems actually occurred about 30 years before the science was fully there, and the argument that I'm going to make today is we are in much better shape with regard to what we understand about the underpinnings of the most important health and mental health conditions that we have in this country, and I'm going to show you that behavioral health conditions are a critical part of that. So, because of that, new infrastructure was constructed in the community. Now, later I'm going to talk about the effects of trauma and poverty and violence. And when we do that, there's a tendency for us to say, well, you know, if you could do world peace, it would be nice too. How are we going to deal with these poverty problems? Some of the problems we confront to us seem as though they're insurmountable. They're just too difficult. We just can't do much about them. Is there a physician in the audience? Looks like somebody is having some difficulty back there. Okay, good. So we've got a little bit of a medical emergency, and I understand that ambulance is on the way, and everything's being attended to. So we're going to go on with the presentation. So, where were we? We were talking about the previous public health revolution, how it changed everything. And the point I was making was that when later we're going to talk about poverty and we're going to talk about violence, and we're going to talk about some things that in many ways as a nation we become resigned to. And when we think about trying to address big problems like that, we kind of put up our hands and say, you know, that would be nice if we could do that, but we don't know how to do that. And what I'd like to do here is just think about the fact that once this germ theory was developed, they said, well, let's see, what do we need to do to address that? Say, well, you know, if you could just put a pipe into everyone's house in Philadelphia or Chicago or New York, where a lot of this started, that could bring in clean water, and another pipe that could remove waste from that house, I think we could make some progress with regard to this infectious problem we have, particularly for waterborne diseases. Can you imagine how impossible that must have seemed originally? So you want me to put a pipe into everyone's house and another pipe to take water out? You want me to develop standards for how food has to be prepared, the temperatures at which it has to be maintained? You want me to develop laws and policies that mandate that people get vaccinated before they can go to school? Those, particularly the infrastructure problems, must have seemed overwhelming at the time. But once we had the theory, once we understood how these problems developed, we were then in a position where we could do things that must have seemed impossible at the time. And what I'm going to argue for you all today is that we have that theory with regard to the effects of toxic stress and trauma on healthy human development. And although it may seem overwhelming, we have the science that can guide us forward in terms of addressing these problems substantially. And we can't be resigned to them because it's just too expensive. It's endangering our health too fundamentally. So what are today's epidemics? And these are some of the ain't it awful statistics about sort of where we're at in terms of our overall health and well-being. About 20 years ago, the United States ranked 11th in terms of global life expectancy, and today we have dropped to 50th. So we're living longer, but we're dying sooner than other comparable nations. And you can see that that's in the context of spending twice as much per person on medical care in this country than any other nation in the world. We're not getting the value out of the healthcare system. The Institute of Medicine has recently completed a study where it compared the health status of United States citizens to those of 16 other comparable countries and determined, and the Institute of Medicine is part of the National Academy of Sciences, it's the premier science group in the United States. And what they determined was that we are at the bottom in most every area of health status relative to the other nations to which they compared us. We have a fundamental problem in terms of how our healthcare system is working. And again, I'm going to argue that behavioral health is a critical part of that. This is something that we've actually known about for many, many years, and this is the excess mortality or early death associated with people who have severe mental illnesses. And as you can see here, sort of average life expectancy is about 78 years. And for people who have severe mental illnesses, their average life expectancy is about 53 years. 8 years of that 25-year difference is probably directly related to the mental health conditions that they have. But as you know, people with severe mental illnesses also have a tendency, number one, to be discriminated against, number two, to have difficulty accessing the healthcare system, number three, to live in poverty, number four, to smoke cigarettes. So there are multiple risk factors that contribute to this excess mortality. But for the people for whom we have been principally interested and responsible for as mental health associations and advocates for the last, and treatment individuals for the last 20 years, we have a health emergency going on. Interestingly, even though the original papers for this were done, at least the ones I'm aware of, in 1934, finally, for some reason, the amount of outrage that has happened in response to this seems to have caused action, and a lot of what we talk about in terms of integration of care kind of came out of these findings. The World Mental Health Survey is a survey that has been done around the around the world, in 17 nations, using standard survey research techniques. So this doesn't involve people coming into care. It's actually going out and randomly selecting residents and giving them a structured interview to determine whether or not they meet diagnostic criteria for a mental illness. And what we know from the World Mental Health Survey is the United States has the highest rates of mental illness in the world of the 17 nations that were studied. That first slide I showed you presented the annual prevalence rate, which is about 25% from that study. Here we present the lifetime prevalence rate, and we contrast non-Hispanic Americans with U.S.-born Hispanics. And what you can see is that our lifetime rate of a diagnosable mental illness is about 50%. So it means 1 in 2 of us at some point in our life will meet criteria for a diagnosable mental illness. The other two bars are people from Mexico, which you can see have rates, lifetime rates of about half of the rates of non-Mexican U.S. nationals. And the yellow bar are new immigrants. Those are people who come to the United States from Mexico. And you can see that people who come here have the same rate as the people in Mexico. So it's not like a Mariel boat lift where the people who are migrating selectively here have health conditions. What happens over 13 years is that their rate of mental illness rises to equal the rate of the general U.S. population. So there's something going on in terms of immigration and integration into this culture, which is making people sick. You know, we have several estimates now of the expense of that this. In 2009, the Institute of Medicine estimated that the costs of preventable emotional and behavioral disorders in kids was about $247 billion each year, which is about almost $300 billion in terms of 2013 dollars. And in 2002, Ron Kessler and colleagues in the National Comorbidity Study, through some very careful work, estimated that the costs of severe mental illness were about $193 billion a year, which is turns out to be about $270 billion in 2013 dollars. And you know, we get used to sort of throwing these numbers around without kind of realizing their consequences. But only Exxon and Walmart in 2013 had revenues greater than the amount of money that we lose by not successfully addressing issues in severe mental illnesses. It's as though we are losing a Fortune 5 company each year by not appropriately attending to these circumstances. Our academic achievement is near the bottom of the OECD nations. The OECD stands for the Organization of Economic Cooperation and Development, and they're the nations against which we compete internationally, all the European nations, Mexico, Brazil. And you can see that we are 21st among there are 34 of them, 21st in science literacy, 24th in problem solving, 25th in mathematics. You can see that our post-secondary graduation rate has fallen from 2nd to 16th by 2005. And recent data shows that these situations, even though we're putting so much emphasis on trying to improve our educational system, we continue to go in the wrong direction. So more recent estimate shows that we've even fallen further from these figures in terms of our academic achievement. We have a big problem with poverty, although it was great to see in the paper yesterday that the Census Bureau has reported that we've made some progress in terms of reducing the overall poverty rate over the last year. But we have about 44 million people who live in poverty, a bit fewer than that now. But we have continue to have a big homelessness problem, and as you all know, that's significantly related to mental health. Lots of kids on food stamps, lots of children, almost 20% of children living in poverty. And that the research suggests that not only do we have a high rate of poverty, but we have a very high rate of difference between people who are in the top economic categories and people who are at the bottom of the economic ladder. So that the degree of inequality in the United States leads the world in terms of the difference between the rich and the poor. And unfortunately, we also lead the world in difficulty getting out of poverty. So moving in and out of poverty are not something that we do well. We live, unfortunately, in a very violent nation. You know, our homicide rate in 15 to 24-year-olds is the highest. Our overall violence rate is 3 times higher than the next nation in the OECD. We have more than 4 times the rate of the next highest country in terms of that homicide rate, and firearm-related deaths are 8 times that of our economic counterparts. You know, as you well know, we have great availability of guns in this country, and that continues to be a very controversial area. If you just look at it from a public health perspective, there's a clear relationship between the availability of firearms and firearm deaths, and I think we know in our community that the rate of death from suicide with the use of firearms doubles that for homicide. We see this in the press all the time. We've got an incredible incarceration. We incarcerate more people than anywhere else in the world, and our rate of incarceration, as you can see, is 7 times higher. We incarcerate about 700 people per 100,000 population. China, about 110 people per 100,000. In France, about 80. So if you looked at a European economic counterpart, we incarcerate people at approximately 10 times the rate. These are all indicators, I argue, of the fact that we have significant health problems in this country, and these are our contemporary epidemics. So how did we get here? What do we know about what's causing it? You know, if we think about Jon Snow again, what have we learned about the root causes of these problems? Well, we've come to understand over the last 2 decades, 3 decades, that it's the interaction of our genetic vulnerability, our genome, and the environments in which we live that produce health and illness. And so we realize and we know that all the major mental illnesses have significant genetic components. They have significant heritabilities. But we're increasingly understanding that it's that vulnerability expressed by your genome in the context of the environments in which you live and grow that's an important determining element in our overall health and well-being. So we know that genetic vulnerability and toxic stress and trauma are risk factors, but we also know that they are protective factors, so that it's possible for us to have skills and resources, and I'm going to show you some technologies later on, which allow us to improve the rates at which people become ill, and environmental buffers, things that help people's social insurance policies. So we know about what we can do to make a fundamental difference here. And looking at the sort of the social determinants of health, the Robert Wood Johnson noted that your zip code may actually be more important than your genetic code. The places you live, the things that you're exposed to, probably have a more profound effect on the development of illness than your genetic vulnerability, although just like we don't want to get into mind-body arguments, we don't want to get into genetic environmental arguments, because I think increasingly we realize that it's the interaction of these 2 factors which are that's most important in terms of health or illness. So the social determinants of health, I think that everybody probably understands this, are the conditions in which we are born, live, and work, the healthcare infrastructure that's accessible to us. They're the non-medical factors, so they're things like trauma, poverty, aspects of the physical environment, and adverse conditions in which kids grow up particularly have been shown to have long-term consequences in terms of their health and well-being. We actually now have, I'm not going to go into it in any great detail today, but I'll mention to you that I've just literally yesterday finished with colleagues 2 papers in which we review the science around the effects of toxic stress and trauma on health and well-being. And if you come up after the presentation and give me your cards, I would be happy to send these papers to you. And our conclusion, we were surprised when this was a project that the Substance Abuse and Mental Health Services Administration contracted us to do. We were surprised at the strength of the scientific literature about the interaction of toxic stress and trauma with biological vulnerability on the production of illness. We're really now coming to more completely understand. It's sort of like Jon Snow 30 years before Pasteur. I'd say we're in about a 10-year gap now before fully understanding how at the cellular and chromosome, at the genetic level, how the exposure to toxic stress and trauma causes changes in terms of how our brain develops. And some very interesting work at the University of Pennsylvania targeting specific areas of the brain that are involved in various types of memory and showing that those are adversely affected by kids who are growing up in lower socioeconomic status conditions. We can test for that early on and start to see some of these deficits developing. And we now understand that these effects become biologically embedded. They become part of our biology. It's easier to understand for young children whose brains are very actively developing through the first several years of life that the effects of these kinds of toxic elements, psychological as well as chemical, literally cause changes in their brain. As you get older, different parts of the brain, which continue to develop through adolescent and young adulthood, are differentially affected. Ultimately, though, the story is that these become biologically embedded in our nervous system, so in our brain principally, but also in our endocrine system. And this is the stress response that we talk a lot about, allostasis and the allostatic load, and the flexibility our endocrine system has in terms of responding to acute stress. And then finally, we continue to understand more and more about how it affects our immunological system. And we know for a long time that people who are exposed to chronic stress have higher rates of infectious illnesses. But we're now finding, and we just had last week at our annual meeting, Jane Costello, who's a woman who's done the Smoky Mountain study, reported data on kids that they're following, who they picked up in junior high, and they're now interviewing them at age 30, and seeing that kids who were exposed to higher levels of socioeconomic disruption or family disruption actually have higher levels of C-reactive proteins in their blood. And those C-reactive proteins are the things that we use to identify people who have inflammatory diseases, and arthritis would be one of a whole host of inflammatory diseases. So the biology is starting to be pretty well understood. We're not quite to where Cook was and Pasteur when they identified that bacillus, but believe me, the story is really becoming quite compelling. The good news is that we also know a lot that we can do to prevent people from experiencing those kinds of traumas, and additionally what we can do to treat people and to start to change the course of some of those disorders. Now, how many people know about the Adverse Childhood Experiences study? You put up your hand. So a fair number, that's good. This is a study that the Centers for Disease Control and Kaiser Permanente in San Diego started several years ago, in which they enrolled about 17,000 Kaiser enrollees. So these people all had health insurance. They were middle class, largely white, non-Hispanic, balanced by sex, and 74% had attended college. So this is not a representative sample of the United States. These are people who we would suspect to have better health than a representative sample, particularly with that level of college attendance. And what they did in the study was initially designed actually as an obesity study done by the epidemiological group at the CDC and Kaiser, was they included a series of questions about adverse experiences that people reported they had experienced as a child. And so you can see here, these are the kind of the general rates at which people reported trauma. So you can see in terms of abuse, about 11%. I have trouble reading the slide from this angle, but you could probably read it better than I can. The point that we're wanting to make is that the rate at which people experience trauma was, I think, higher than many people would have expected. There have been many other studies now looking at traumatic exposure, and trauma is very common. What they did in the ACE study was they gave everybody an ACE score, and that ACE score had to do with the number of areas in which you had experienced trauma, not the number of traumas that you had, but the number of areas. So it can go from 0 to 10, and they found that people who had ACE scores of 4 or more, as opposed to people who had 0 ACE scores, were much, much more likely to currently have both mental health and general health problems. So you can see they were 7 times more likely to have alcohol abuse or dependence, 10 times more likely to have drug abuse, 5 times more likely to have depression, 12 times more likely to have attempted suicide. But they also were twice as likely to have heart disease, twice as likely to have cancer, 4 times more likely to have COPD, and other chronic kinds of conditions. And this really surprised people. And if you look at people who have ACE scores of 6 or 7, the number of problems they have just continues to multiply. And this study has had profound effects. There have been over 80 papers published using these data. But what we found from this current literature review we're doing that this is an observational study where you get people when they're adults and you ask them to report what happened to them as a child. And of course, it's much better if you can follow kids prospectively. And we now have several studies that have followed kids prospectively or have looked at kids who are in foster care versus matched kids who aren't over time, and find out that the things that the ACE study demonstrates for us are replicable and occur in other kinds of populations as well. Now we start to get to the heart of the matter, in a sense. Remember that we used to think that mental illnesses and addictions were really diseases of early adulthood. And what we now know from very carefully done epidemiological studies are that these are developmental conditions that occur early in life. So we used to think that people would become ill in their 20s. We now know that half of the people who are going to have a lifetime diagnosis of a mental illness will have that diagnosis by age 14. Most of them will have had significant symptomatic expression 2 years earlier than reaching the diagnosis, so that's age 12. We also know, unfortunately, we're getting better on this, but we're not where we need to be. We also know that on average, those kids will not receive treatment for those conditions until age 24. So again, think about this developmental sequence we're talking about. Things that happen early in life start to cause behavioral health problems. We are very poor at identifying those problems or on following up on them. And so from 14 to 24, kids have these problems. We know that then leads them, it increases the likelihood that they perform poorly in school. They miss school, they drop out, they start to abuse drugs and alcohol, they have poor occupational goals and achievements. And this leads us to what I call sort of what I think will be the new general theory, which will be the next generation's germ theory in terms of organizing our thinking. And here's how it works. So we start with having some genetic vulnerability. We know from all the heritability work that genetics are an important part of our developmental schema generally. And if you then combine that with the exposure to toxic stress and trauma, and you saw the list of traumas, and that list that they use in the ACE study is a very common list that's used across many, many research endeavors now. What that leads to, and the earlier it occurs, the more dramatic and long-term the effects are, is it starts to lead to this notion of allostatic load, which is an inability to manage stress effectively, increased levels of cortisol, changes in terms of brain development, which ultimately then involves endocrine systems and immunological systems. The first symptoms to start to show up as a result of those exposure are behavioral health disorders, if you think of the general population, right? And we can think about those both in terms of diagnosable illnesses that occur about age 14, we don't get treatment until age 24, or these other kinds of learning deficits that we're getting clearer and clearer about, basic cognitive abilities like working memory, language acquisition skills, et cetera, et cetera. So think of behavior broadly and not simply in terms of psychopathology. We know that we're not very good at identifying those disorders and responding to them. So during that interim, that 14 to 24 year period, kids have a tendency to increasingly get worse, start to develop disability. They start to show problems with their academic functioning. We just talked about that. So they have compromised academic functioning, achievement, and social functioning. So they start to hang around with deviant peers, start to pick up cigarettes, start to drink or use drugs. As their academic achievement goes down, their occupational achievement is also depressed, right? So that they're not as likely to be as successful occupationally as they might be in other kinds of situations. As your socioeconomic status is depressed, your occupational achievement is depressed, we know that you are more likely to continue to be exposed to toxic stress and trauma, as well as to develop chronic illnesses. So we created what we call a vicious circle, right? So you start off, you're vulnerable, you have trauma, it's affected in terms of your biological embedding of these problems. That's reflected in terms of behavioral health disorders, affects your performance in school, affects your performance in your occupation, puts you at greater risk for toxic exposure, and you re-traumatize. And think about bringing children into this vicious cycle, right? Where they're exposed to that. and again, the data for this is very strong. I'm not going to spend much time on this slide. This is a slide from Braverman that was in the annual review of public health several years ago, and it basically just shows that if you're interested in health, educational attainment, which is one of the major determinants of socioeconomic status, how well you do in school, how far you get in school, is really an important determinant in terms of health behaviors, health knowledge, and ultimately many, many aspects of your health. So I think a compelling story has really developed here around what we know are our current infectious elements, and it's an opportunity for us to do something about it. And fortunately, we know a lot about what we can and what we should do. So we have in 2009, that same Institute of Medicine of the National Academy of Sciences did a really comprehensive review of the mental, emotional, and behavioral prevention and promotion technologies. You know, prevention are things that we use to reduce the prevalence of illness, and promotion are things that are known to increase the overall levels of health. And so what they found was that we have a formidable science base and that we can implement with regard to prevention and early intervention by both reducing community risk factors and increasing a resiliency of individuals and communities. And what we're going to do is just talk about a few that, like I said earlier, we could really characterize almost as behavioral health vaccines in terms of their effect. Abuse, child abuse, we know particularly for very young children, has very severe long-term consequences in terms of kids' health and well-being. And fortunately, we have a series of very well understood interventions which we know can reduce child abuse. So probably the best known of these is David Ohl's program around home visitation that actually has reduced child abuse rates by as much as 40%. And this is kind of a success story because Ohl's intervention, in part largely because of David's enthusiastic work in the area, is now becoming more routinely available throughout the United States. Home visitation programs are very important and can have profound effects. There's a program called Triple P, the Positive Parenting Program. Very interesting program. Has 5 levels, a universal level, which is a public education campaign about effective parenting techniques, and then 4 levels that deal with different levels of parent education and ultimately treatment. That's been shown on a county level. So you implement this in a county, it's parent education plus general public education about parenting, reduced the level of child abuse in the county by 29%. And this is experimental counties and control counties, and so they were able to map the effects of this Triple P, 29 to 30% reduction. And the Olowitz bullying prevention program also can reduce bullying in schools by about 70%. So reducing risk factors, at least with regard to child abuse and bullying, we have some significant science to help guide us. That we have long-term follow-up data for kids who are served in the visiting nurse programs. And those kids are more likely to graduate from high schools. They're less likely to go on to Medicaid or public assistance when they're adults. They're less likely to smoke cigarettes. So the great thing about prevention interventions is they have broad-scale effects on overall health, right? Just like clean water, safe food, broad-scale effects. This is 15-year follow-up data from the Seattle Social Development Program. Now, the Seattle Social Development Program is a program that's done in elementary schools, cleverly named Seattle since it was developed at the University of Washington. And as in a few of these studies, they've been fortunate, our colleagues Hawkins and Catalano have been fortunate and been able to follow up people, and they're now interviewing people. They're actually now interviewing people who are in their 30s, but these data come from people who were interviewed at age 27. Now, the intervention ends at age 12, right? So when kids go from junior high to middle school, the program no longer continues. So these kids haven't had any intervention, systematic intervention, for 15 years. 15 years later, you can see that there's a 38% reduction in terms of the rate of diagnosable mental illnesses. And that's why we argue that these function much like vaccinations. I mean, we're seeing effects from the nurse partnership 12, 13 years later. The good behavior game is another intervention, and this is one that's done in first grade, developed initially by a teacher, and then subsequently further developed and tested by researchers at Johns Hopkins University. And this is a game. It's based on basic behavioral principles that kids play in the first or second grade that differentially rewards them for good behaviors. It's not terribly complicated. It turns out that here we also have longitudinal data 13 years later. So 13 years after the intervention was delivered, nothing systematic that we're aware of happened in the interim. We saw a 36% reduction in special education placements, a 21% increase in terms of high school graduation, 61% increase in terms of college attendance, and they're about a third less likely to abuse alcohol. This is 13 years after the end of the intervention. These act like behavioral vaccines. We also know that through very careful work that's been done, a lot of work for some reason has been done in Washington State. In Washington State, they have something called the Washington State Institute for Public Policy. And this is a group that was created by the state legislature, and they describe themselves as like a portfolio manager for the state legislature. So their job is to inform the legislature about where they should invest their money, where they're going to get the greatest return on investment for their money. And it's been very successful. Washington State has taken about 2,000 prison beds off of their construction schedule based on the work of the Washington State Institute, and put the funds that would have been used to build those prison beds into prevention programming. The Pew Memorial Trust and the MacArthur Foundation are so impressed with the work that's going on in Washington that they have a project in which it's called the Results First Initiative, in which they're trying to continue to roll out this type of methodology, and they're working in several other states. But the data from the Washington State Institute on Public Policy shows that we have significant returns, positive returns on investment for our prevention programming. So early childhood education, you could see they estimate costs about $7,000, but the benefits in terms of improved educational outcomes, reduced crime, reduced child abuse and neglect are valued at about $17,000 in this analysis. So it shows that for every dollar invested, we're getting almost $3 in terms of return. The nurse-family partnership I just talked about a minute ago with the long-term data, here it's a little bit more expensive intervention, costs about $9,000 a year when these data were collected, but they have the benefits in terms of reduced crime, reduced child abuse, improved education outcomes of about $26,000. So here you're showing, about a $3 return for every dollar invested. The Seattle Social Development Project, that's the one I just showed you, that has the long-term effects in terms of reducing diagnosable mental illnesses, costs about $4,500, but they estimate that there's about $14,000 in benefits from it in terms of reduced crime. And see, what they've done here is something that we don't do ordinarily and routinely, and that's they've taken a look at all the effects of these prevention interventions. Oftentimes we only look within whatever particular silo or category we're interested in. Here they're looking at the broad scale effects, which is a public health approach to what we're doing. And you can see here they estimate that it's about $3 returned for every dollar invested. And Guiding Good Choices, which is also a program by the Seattle group, it's a very simple, short program. It's relatively inexpensive, and you can see that it has almost a $10 return for every dollar invested. These data have been very carefully peer-reviewed twice now, I think maybe a third time. And economists who are, I don't know if we have any economists in the audience, but economists are kind of, it's called the dismal science, and they're very critical, these economists. And they brought economists in, and they've reviewed Steve Osis' methodology and basically find it to be sound. This is the direction that we need to move in terms of thinking about the effects of the conditions in which we're interested on overall health and well-being. And you can see even from those three interventions that I featured for you, how those specific interventions have broad-scale effects on socioeconomic status, on well-being, on decreasing the rates of behavioral health disorders, and it's in our enlightened self-interest to implement them. So what did we learn from the past in terms of implementing public health movement? So we learned that by we could reduce community risk factors by doing things like draining swamps and building sewage systems, right? And again, think about when that was initially proposed to people, how impossible that must have seemed. That we could strengthen community protective factors by building safe housing, paving streets, reducing the level of dust. This is the germ theory. Decrease individual exposure to pathogens with antiseptics, sanitation, and quarantines. Again, thinking about what's happening in West Africa right now puts this in sharp contrast. Increase capacity of individuals to resist infection through vaccinations and curing infections with antibiotic treatments, right? So we had a whole series of strategies that we used in terms of implementing the germ theory. And we can do the same thing with regard to the factors that are underlying our contemporary epidemics. So we can reduce community risk factors by assuring safe and resource-rich neighborhoods. I know that our colleagues here in Tulsa and Oklahoma have done a tremendous job in terms of housing development for people who are homeless or at risk for becoming homeless. We can do work in jail diversion and juvenile justice settings. It's so important, I think, that we kind of rediscover the importance of rehabilitation in those settings. And we can see that a lot of the interventions that we talked about, right, the nurse partnership intervention, for example, reduces the rate at which kids become involved with the juvenile justice system. And we know that kids who are developing these behavioral health conditions, age 14, don't get care. One of the things that they routinely do is bump into the juvenile justice system, and we can argue that that's, in fact, a pipeline to adult prison. There are various social policies that we can implement. You know, social insurance programs make a big difference. You know, it's interesting. A group at Yale has taken a look at expenditures for health. Remember I said we spend twice as much on medical care than all of our competitive nations, right? And we have much, much worse outcomes. What the group at Yale did is they took the amount of money that was spent on health and they added to it the amount of money that was spent on social insurance programs, things that help ensure people access to health care, a basic safe place to live, et cetera, et cetera. And it turns out when you combine those two and then look at how we compare to all of our economic competitors, we're not that far of an outlier. We're spending about the same amount of money. But what's the moral of the story? They're getting much, much better health outcomes than we're getting because their investment portfolio is different, right? It's like continuing to build prison beds when we know we can invest in things that will reduce that the juvenile jail to justice to school to prison pipeline. They're doing it in Europe. Colleagues report that we had the original ILM report was done in 1994, and what colleagues in Europe report is they took the findings from that, which we kind of ignored in our country and implemented in their country, and they're getting the benefits of that now. So we have a lot that we can do in terms of strengthening community protective factors. We can reduce individual exposure to stress by lowering child abuse and neglect, bullying, violence, poverty. We know we can do it. The article yesterday in the New York Times about what's happening with regard to poverty in this country shows that back when we had the war on poverty, we had gotten poverty rates down around 11%, and they're currently up near 20%. So even in our lifetime, we can show that if we move aggressively on these kinds of problems, we can do something about them. We can increase individual resilience by skill building and implementing behavioral vaccines, right? A lot of those interventions that we talked about had to do with basic skills, negotiation skills, management skills, classroom management skills. And like I said, you know, you can see 13-year, 15-year, 20-year effects that even surprise the investigators that they're continuing to see these effects 20 years later. And we can contain the effects of toxic stress through treatment that's accessible, evidence-based, and reimbursable. I haven't, in this talk, talked much about treatment for people who are exposed to traumatic stress or who develop depression or anxiety disorders or schizophrenia. There's meta-analyses that show now that kids who are traumatized are 3 times more likely to develop psychotic illnesses than kids who are like them, who haven't experienced that trauma. Anyone's interested in that literature, come up afterwards and I can give me your card and I'll be happy to send you that paper, which will also be available on the MHA website. I haven't talked much about treatment, but there's a whole armamentarium that we can do in terms of treatment as well. And remember that the thing about do you want vaccines or antibiotics, we are in the same situation. We want both prevention and treatment and we have to continue to work together as a team to get that going. So what's needed to create the momentum? The second, we're arguing here that we now have the science base that should lead us into what will be the next major era in public health. And there are some things that have happened recently in terms of healthcare reform and the Mental Health Parity and Addictions Equity Act, which are going to be very helpful in terms of focusing our attention on that. My argument is that our theory is now a lot better than John Snow's theory when he removed the Broad Street pump handle in terms of his work on cholera. And that what we need is a better story, a better way to communicate this, and we need political will. We need the action, and that's part of the call to action that I'm going to give to you today. What are some of the social policies that could make a difference? We've made important progress over the last year in terms of getting closer to universal insurance coverage. I have another paper that if you guys are interested in, I feel like I'm hawking my papers, but they're free. So I mean, there's no, I don't get anything from them in terms of financial remuneration. I wish somebody would pay me would sell these papers. Maybe I need to do that. Maybe a very popular book. The things completely, the dynamics of health coverage completely start to change as we get close to universal coverage, and as insurance companies can no longer deselect people who are ill, right? So there's no longer pre-existing conditions can no longer exclude you from receiving care. The incentives to keep people healthy start to fundamentally change the closer we get to universal coverage in insurance and companies' inability to deselect people who are sick. That's huge. And as you all know, this is very much a work in progress in terms of continuing to try to implement the program. There are lots of issues with it, but I think the principle of universal coverage is absolutely essential. We know that tax policy can be very helpful. We know that if we tax cigarettes more, kids who are particularly sensitive to prices of things are much less likely to smoke. We have higher taxes on alcohol and other kinds of the situations. We reduce the rates at which those use. So taxes are an effective element of social policies. Family leave policies are very important. A lot of really very important stuff happens between babies and their caregivers in those early years of life. Our European counterparts who are getting much better health status outcomes than we are. Many of them have very liberal family leave policies that allow people to spend much more time with their newborn infants over their first 2 years. We need surveillance activities. You know, if you can't measure it, you can't change it. Things like the National Survey of Drug Use and Health and the Behavioral Risk Factors Survey, Surveillance Survey, are giving us some of those data. So we now have the ability to do better estimates of how we're doing in terms of diagnosable illness, in terms of the exposure to those things that are risky. It's my understanding that several states, I don't know the story for Oklahoma, but several states have added those ACE indicators to the Behavioral Risk Factors Survey, and that's going to give us the ability to start to see, are we actually starting to drive down the rates at which people experience those traumatic events. It's like sampling the water to make sure that the level of E. coli that are in it are safe, right? We don't measure it, we can't change it. Gun laws, I know this is something that's, I just heard this morning on the radio about voter registration efforts and things that the National Rifle Association and other groups are doing to increase voter participation. The data are clear that the availability of guns is associated with all sorts of untoward health outcomes. States that have stronger laws that make it more, that regulate access to guns more energetically have reduction in accidental deaths and suicides. Remember that the issue about violence, guns are an important part of that story. And school discipline reform, policies to manage classroom behavior may support school to prison pipeline. My own nephew, who had bipolar illness in Pueblo, Colorado, was successfully extruded from the healthcare system, from the education system in Pueblo. Fortunately, he was able to go to because my family had resources, he was able to go to a boarding type program, behavioral health program in Utah, and graduated from high school. But if my sister hadn't intervened so effectively when Kyle kept getting in trouble with minor offenses with the law, he could have easily ended up in the juvenile justice system. And the school system, rather than serving him as they should have, successfully extruded him and permanently expelled him. So we need to tell the story more effectively. I don't think people in general understand the strength of the science, and we need to understand better ways to communicate this to the general population. There's a really interesting book that was written by Nancy Tomes about the implementation of the germ theory, and it was actually the concurrence of interest between the soap industry and the sanitarians that were an important part of energizing the sanitation movement. So we need to find allies who can have commercial interests as well as what we know are important public health interests, I think, to tell the story better. So we've got a compelling theory, but we need to be able to explain that faster and more compellingly to people. You know, in terms of the interaction of our vulnerability and our toxic stress and trauma and how they cause changes in our basic biology that have lifelong impacts, that we know what we can do about them, and that what we need to be able to do is to impress upon people, like they did in Washington State, about how important these investments are and how they're going to pay benefits across a broad spectrum of our health and well-being in our country. And we need to, you know, it's funny, when cholera was an epidemic that caused a lot of concern because you could literally watch it move. So you could see it, a cholera outbreak would start in Europe, you could watch it move across Europe, come to England, to the United Kingdom, then it would cross the ocean, would be in the United States, and then you could map it. So people were very concerned about cholera. They weren't concerned about, to the same extent, about yellow fever or tuberculosis, because those were endemic. They were always, tuberculosis and yellow fever were always present. What's happened to us, I think, is we've become resigned to this very poor level of human capital productivity in our country. And we don't think that there's anything that we can do about it. You know, when you have a shooting, like at Sandy Hook, that can motivate people to wonder about what they can do, often with very untoward effects in terms of what we think about people, in this instance, who have mental health conditions. Somehow we need to inspire people to realize that we have a much more potential than we're realizing now, and that we've got compelling reasons to do this. We're wasting too much human capital. We need to tell that story more compellingly than we have. And we know what to do in terms of we have proven technologies. The science is going to get better. We're going to understand more about how stress causes differences in the epigenome, literally differences in how chromosomes express genes, how it causes differences in terms of how glucose is metabolized in the cells. That science is going to be developed. It's being developed right now. But we definitely have enough science to inspire action. These are very high leverage investments, as I showed you. You invest in nurse-family partnership, you improve a broad range of outcomes, multi-generationally, right? Multi-generationally. And conversely, some of the trauma and toxic stress that people experience also have multi-generational effects, both in terms of the sort of the vicious circle general theory we talked about, but increasingly we're understanding that some of those effects literally get embedded in the germplasm, in sperm and ova, and are passed on genetically across generations. There's some very interesting rat research where rats who were stressed as young rats, which are called pups, have predictable biological changes, and they find that those biological changes show up in those rats' offspring who have never been stressed. So there's even a biological channel that we don't fully understand yet that's affected by these kind of environmental interventions. Very different than what I learned when I was learning my genetics as I went through school. We have a whole new set of understandings with regard to that. And something that I've not been very effective at today is using narrative and metaphor. We've talked a lot about metaphor. We talked a lot about the last public health revolution and the next public health revolution, but we need stories, I think, to do justice here. People remember stories. They're kind of impressed by data, but they remember our stories. So chances are if we tested you a couple hours from now, you probably would remember the story of Kyle, my nephew, but probably less likely to remember the results of the World Mental Health Survey. Maybe we should do a test, Michael, and see. What do you think? So, final thoughts. First is, that this is all very personal in some ways. So it's important that we incorporate these things into the way we live our own life up to our own potential and do what we can to manage stress more effectively, to understand and to track the effects that it can have on us. We need to collaborate in creating political will to get the science that we know can make a difference in action. We need to get in action. We need to create a sense of urgency. We need to bring together, and this may anticipate, I was talking with Karen LaPlante this morning, this may anticipate next year's agenda in that we realize now that general health without behavioral health isn't going to work. We know that behavioral health without social health isn't going to work. We have a lot of investments in our country in these areas, and somehow we need to better focus and collaborate with what we have, identify where we have shortages or shortfalls, and move aggressively to try to fill those holes. You're all here. You're part of the Mental Health America movement by being here. I encourage you to continue to work with the Mental Health Association in Oklahoma. I mean, this is, remembering going all the way back to Clifford Beers and William James and Adolph Meyer, this is our legacy for our organization. This is what we have believed in for 105 years. We now have the science to carry that forward, so I encourage all of you to get involved with it. You've got a very good mental health affiliate in your area. If you didn't, I would encourage you to create one. Or maybe you can make sure that Mike Rose makes sure there's a mental health association in every city over 25,000 in Oklahoma. I know he would appreciate that. And finally, we have an action center, an electronic bulletin board at Mental Health America that we use to try to inform Congress about important things that are happening. And I very much encourage you to go to the Mental Health America website, and you can join that group and start to become part of the political will motivating movement that we need to get things going. So, what have we learned today in terms of prevention and the next public health revolution? I think that it's very clear to me that we now have compelling reason to be concerned about our overall health and well-being. We know that chronic illnesses, of which behavioral health conditions are the most chronic, cost us from 75 to 90% of our overall healthcare expenditures. We're increasingly learning that those chronic illnesses, the roots of those chronic illnesses start in early childhood. They start prenatally, actually, before children are born. It's very important that pregnant moms get the nutrition and live in safe environments as those babies develop in utero, and clearly once they're born. We're increasingly developing very strong data that shows that the roots of heart disease and diabetes, lung disease, arthritis start in very young children, and that this will be the next public health revolution, is realizing these antecedent conditions and doing something about them. That we have significant technology and science to guide us in this regard, and that the stories that are developing are quite compelling about how these things work at the cellular and subcellular level. It's not there yet, but it's getting closer all the time. So my call to you is to join us in this movement. We're at a tipping point, but it still requires that we push things over that precipice. This is our legacy. This will be the next major era in public health, prevention in everything, an amped theme for this conference. And I hope that if you're interested, you'll come up and I can send you these papers we just worked so hard on, and then you'll join the Mental Health Association in Oklahoma or mental health associations in your state as a voice for what we must do to address our contemporary epidemics and make the difference that we need to. Behavioral health is the linchpin. Thank you. Joking, I didn't think I could talk that long because I thought I was supposed to talk about 45 minutes, and then I noticed because I wasn't paying attention that I had an hour and 15 minutes, and my wife said, you know, if they gave you 4 hours, you could talk 4 hours long. So I actually talked the entire hour and 15 minutes. So Al?
And you did a great job. Thank you so much, Dr. Shern, for sharing the amazing work and breakthroughs going on in the mental health revolution that will make a difference for all of us, especially those impacted by mental illness. We have a few minutes, so we want to open it up for questions. We'd like to invite all of you to be a part of the discussion and ask that you please go to the microphones in the audience so that everyone can hear your questions and comments. And then after the questions and comments are addressed by Dr. Shern, I have a few more announcements to make before you proceed to your breaks and next breakout sessions.
Yeah, and the microphones are up here, so people who are reluctant to come to the microphones.
Thank you, Dr. Shern.
Yeah.
Appreciate your leadership. Part of the last public health revolution, in many ways, was moved forward by the use of public health laws. And I know you touched on that a bit when you talked about social and regulatory related issues, but if you look at the last public health revolution, we have laws that dictate, for example, food service related issues. Vaccination is another one of those. I guess I'm curious about if you could just give a few minutes on how you see that relationship in the next revolution relative to mental health prevention and treatment. And I'm thinking about court-ordered related treatment, for example, or prevention-related strategies. Thanks.
Yeah, well, I think that we start to see lots of things actually starting to develop. Remember that what we're arguing is that this is the next great era, but it's not as though it starts at a single point and continues on. There's lots of things that have been ongoing that I think are reflective of these issues. You know, Mark, I talked about the Affordable Care Act and universal coverage, the accountable care organizations. So there's a shift in terms of healthcare reimbursement potentially to look at population health and to move away from a disease model exclusively and more into a health prevention promotion model. So I think that's an important part of it. We've got the kind of our challenge is, you know, the exciting thing about prevention is it has these broad scale impacts, but that also means that our investments are spread across pretty much every area of government. So the Department of Justice works on issues of violence and abuse. You know, the Violence Against Women's Act had a major effect, and this is also very contemporary in terms of all the stuff that's going on with the NFL and domestic violence. The Agriculture Department in terms of health and nutrition for kids, which is important for brain development. The Health and Human Services has a huge number of programs. HRSA underwrites the visiting nurse program, which is also Medicaid reimbursable in many states. And SAMHSA has, you know, the National Traumatic Stress Network, which is very important. Increasingly, with NISDA, it wasn't 10 years ago. We had no ongoing survey like the National Survey of Drug Use and Health. I'm almost certain that that's the case. So our surveillance is getting better. So my sense is that there are pieces that are in place. And what would be very helpful, perhaps, is to have something like the National Health and Well-Being Act, sort of like the Clean Air Act or the Clean Water Act, that started to create a structure within which we could fully appreciate our investments overall, and perhaps remove some of the barriers that exist around the sharing of data. That's so important in terms of understanding how well we're doing. Now, you mentioned court-ordered treatment. I think for me, that starts to talk about the things that are going on in law that help to support what we know makes a difference in terms of behavioral health overall. I'm struggling for the term, but it came to me. You know, it's just when you get older, it just takes 7 seconds longer, I think. This notion of therapeutic jurisprudence, right? Where we think about how can we use the law therapeutically rather than just punitively. I mean, it's very clear, at least to my reading of the data, that our mandatory sentencing laws, our attempt to try to deal with substance abuse problems through incarceration and severe punishment have been a massive failure in terms of addressing those problems successfully. And I think that the drug czar and others have now concluded that the best investments are in prevention. So I think that to the degree to which laws can reflect a more rehabilitative orientation, things like drug courts and mental health courts have been very popular, thought as successful to try to get people who are starting down that course redirected towards a healthier set of alternatives can be important. So I think a legal structure that helps to understand our investments and understand where we need to make more investments. I think that things like therapeutic jurisprudence, where the rubber hits the road, involving treatment much more actively in those kinds of situations, are all part of the public health infrastructure that's developing. It's not adequately understood or funded at this point in time. Anything else? I know it's always hard to go to the microphone, and then if you put the microphone in the front of the room, it makes it even harder. You really need to be brave to come up. But here's a brave person.
I'm going to try.
Huh?
I'm going to try.
Okay.
I noticed that you mentioned a bullying prevention program. I wondered if you had any ideas or thoughts on a teen pregnancy prevention program. I know myself, I see a lot of that in the high schools, so just thought you could give us some ideas.
Yeah, well, you know, and we've been successful in terms nationally as we part of the good news in some of the public health interventions is when we really concentrate on it, we can make a difference. We can make things happening. And teen pregnancy is an area in which we have had some successes in terms of we monitor the rate. There are various technologies. And I'll be honest with you, I'm not intimately aware of what those technologies are, but that when they're implemented well, they start to drive down teen pregnancy rates. If you think about the teens are more likely to be immature themselves, right, when they have their babies. The fact that they are probably not likely to be wealthy, and so that what we're doing is we're creating a circumstance in which young children are born into environments that are going to prove to be more stressful and perhaps more abusive, not necessarily so, but I think that the risks would be higher. So that's sort of responding to the earlier question. That's another important piece of what needs to be an overall strategy in terms of addressing the issue. Many of the moms who are served in that nurse-family partnership are the program is designed for first-time, low-income moms. So many of those moms are teens when they become pregnant. And what we find is moms who participate in that program, not only do they get the coaching that they need so that they can more successfully bond with and attach to their child, they're also much less likely to get pregnant again over a shorter period of time. So it actually has a family planning effect, which decreases the rates at which people are exposed to it. So thanks for asking that question, being brave and coming up here. Teen pregnancy prevention is an important part of this story, and we may not think about it as having this kind of unfolding effect over the lifespan, but I think that increasingly we realize that it does. What do you think, Al? Thank you all very much.
Thank you so much again, Dr. Shern. We appreciate all the wonderful comments and the information and insights you provided us this morning. As you may know, this evening we're hosting a very special Visionaries Dinner in celebration of the 20th anniversary of the symposium, and to honor the conference founders, Maxine Zarrow and her late husband, Jack. Tickets are still available at the main registration desk. If you're not sure if you're signed up for the dinner, please ask the registration desk staff. Now, time to take a break, stretch our legs. Our coffee break this morning is sponsored by Creoaks. Coffee stations can be found in the ballroom gallery, and please enjoy compliments of Creoaks. Breakout sessions are located in the West meeting rooms. Those sessions located in Ballroom 1 and Ballroom 2 can be accessed from the ballroom gallery. One final and very important note: the Cox Business Center staff has a very short time to get this room ready for lunch. So we ask that you please take everything with you and make your way out into the hallway quickly so they can set up. Lunch will be in this room and will begin at noon. Thanks again for being here, and enjoy the 20th Annual Zarrow Mental Health Symposium.